Hello. I wanted to thank you all for coming. My name is Joe Leeson Schatz. I am the director of the speech and debate program here at Binghamton. Tonight, we're having a debate on a very important issue affecting Broome County, which concerns the heroin epidemic that's facing this area. And both sides will present different ideas of how we can deal with the treatment for the people who live in our communities in order to help create a well-rounded informational debate where instead of having two sides argue at each other, help to inform the audience of the positions in its entirety and with depth and coherence. And in that regards, we have two experts in the field. We have John Barrett, who is the Executive Director of the Southern Tier AIDS Program and a supporter of safe injection sites for heroin users. And we have Alan Wilmarth, the Executive Director of New Horizons Alcohol and Chemical Dependency Treatment Center at United Health Services, and he opposes safe injection sites. And the purpose of this debate, again, is not for you to formulate this is definitively what should be done, but help to give you the basis of information so that way you can make your own decisions and understand how we can address people in our community. And with that, I'll turn it over to Rob Hitler, who will serve as the moderator for tonight's debate. Thank you very much.
Good evening and welcome to this You Defend It debate. As you heard, it is being co-sponsored by the Speech and Debate Team at Binghamton University and Defend It, Inc. My name is Rob Kilmer. I'm the founder of Defend It, Inc. and will be moderating this debate. Last night we had an election. In January, a new president will be sworn in. And we'll begin the traditional process of issuing executive orders and prevailing upon Congress to transform his agenda of campaign promises into laws. Many issues will be on the table, some new, some revisited. Executive orders and laws have consequences. Those orders and laws must be based on provable facts. Americans should have a realistic understanding in advance of how their lives will actually be affected when ideas become the law of the land. Most importantly, Americans need to be able to agree on facts even if they don't agree on the solutions. That is step one in getting back to a place where we, as a nation, are able to actually talk through and think through solutions to important issues about which we disagree. You Defend It debates are different from other debates, both in purpose and in format. The purpose of a You Defend It debate is to take important and controversial, in some cases, many cases, divisive issues and break them down to their factual realities. Emotional arguments have no place here. By requiring debaters to fully defend their own positions rather than attacking their opponents, people who attend this debate or watch it via live stream will have actual facts to actually talk about when the debate ends, and will have a clear picture of how their lives will be affected if either debater's positions becomes reality. The format is simple here. There are only two rules. Each debater must directly answer the question, and each must do so without reference to the opposing debater or the opposing debater's positions. In other words, each must put forth his own positions and defend them. Because the debater's positions are different, they will rarely be asked to respond to the same question. Instead, the questions and follow-up questions will be designed to provide the public with the facts that support the arguments. The debaters will have 3 minutes to respond to the initial question, and then I will ask as many follow-up questions as I think are necessary to provide relevant information to the public. Tonight's issue is treatment for heroin addiction. Within that issue, we will be spending significant time on the issue of safe injection sites. The City of Ithaca has applied to the New York State Department of Health for a permit to open a safe injection site there. There are now approximately 100 safe injection sites operating in 9 countries around the world. The first North American supervised injection site opened in Vancouver, British Columbia in 2003. Heroin overdose is the #1 non-natural cause of death in Broome County. By any realistic measure, it is an epidemic. out of respect for and in deference to the people who have such an enormous stake in the outcome, the audience will be asked to remain completely quiet throughout. As difficult as it might be, we owe it to ourselves for one night to conduct a debate that is accountable but civil. For my part, I promise to moderate a debate worthy of the issue itself and worthy of the people whose lives have been affected by this issue and will be affected by the outcome of this debate. So let's get on with it. Both debaters tonight care deeply about and have dedicated their professional lives to people suffering with addiction. Tonight's first question is for John Barrett. You are one of the primary supporters of the safe injection site for which the City of Ithaca has applied for a permit. What is a safe injection site?
Well, I think to understand, we need to have some background about how we deal with drug use. And generally people talk about the four pillars: law enforcement, treatment, prevention, and harm reduction. Safer injection facilities are a harm reduction intervention. I know that language is foreign to some people, so I'll read you a definition of what harm reduction is. Harm reduction is a set of practical strategies and ideas aimed at reducing the negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. Or as I like to shorthand it sometimes to people, we are trying to keep people alive long enough to quit. So a safer injection facility, in a very real sense, is of course a place where people can bring in illicit substances and they can inject them under medical supervision. But there is so much more to it. There is medical care provided. We assure that the injection equipment is disposed of properly. In Ithaca, we have shower and laundry facilities. We provide assistance with basic needs like housing. We certainly refer many, many people to treatment, and we are a support for people, again, until the time that they can lessen their drug use or stop it completely. So ultimately, the goal of a safer injection facility is the same as our friends in the treatment field.
Okay. Next question is for Alan Wilmarth. There were 58 opioid overdose deaths in Jerome County through August of 2016. You cannot be satisfied with the treatment options for opioid dependence. What treatment options would you add?
Well, I think, as John said, sometimes we have to have background to answer a question. So I'd like to start by backing up a little bit. And one of the things I think it's important for people to understand is that we have very limited options when it really comes to the actual treatment of substance use disorders. As a country, as a nation, we've talked for decades about achieving parity in access to treatment and insurance coverage for people who suffer from both mental health and substance use disorders, and yet we still do not have that. The rules that are applied to accessing existing treatment services are very different for people suffering from substance use disorders than they are for people who have cancer, or people who have asthma, or people who have diabetes. And so that leads me to believe, and to continue to hold the belief, that as a society, we still fail to view substance use disorders as a primary, chronic, progressive disease that is relapsing in nature, and if left untreated or if unsuccessfully treated, is fatal in most cases. So as far as additional treatments that I think ought to be offered, I think there should be far greater access to research dollars for the development of medications that can be more effective in impacting the level of craving that people have. For an individual who has stopped using a substance on which they are physically dependent, they physically don't feel good and their brain has been changed to cause them to have a continual drive to relieve that pain or relieve that symptom. And the way they get that is to return to use. And yet we have very few medications that have really been put on the market for treatment of substance use disorders. We have methadone, which has been around a long time. We have buprenorphine, which was available in Europe for a very long time before it got approved in this country. We have Rivia for cravings for alcohol. We have antabuse that makes people sick if they drink alcohol. We have Vivitrol, which can block opioid effect in the body. But really, beyond that, we don't have a lot of medications that are effective for the medical management of the physiological symptoms that people have when they stop using. So I think we have to do some research and develop medications that can be helpful. I also think access to longer periods of treatment is essential. In working with most managed care companies in the inpatient side, we're lucky to get 10 to 14 days of inpatient treatment. People aren't even through the acuity of withdrawal that they feel when they first start using at that point in time. Fortunately here, starting in January, we'll have 14 days for people who have an opioid use disorder. That's a step forward. But we need to have access to longer-term residential treatment, more intensive outpatient treatment, and safe housing for people who are in recovery.
How much longer?
From my perspective, rather than this 10 to 14 days that we currently get, I believe for inpatient treatment to be effective, it has to be, the acute phase could probably be close to a month. Beyond that, I think acute residential treatment, such as something like the KU Addiction Recovery Services, which is also in Ithaca, that 6 months to 7 month period of more intensive inpatient or residential supported treatment is essential. And if we can't access that level of duration to inpatient or residential treatment, many of the people will continue to relapse.
John Barrett, a safe injection site being proposed for Ithaca would function similarly to the site in Vancouver, British Columbia. Is that a fair assessment of what you envision with respect to the safe injection site in Ithaca?
We'll have medical staff on site, and I think Vancouver does, but I think their medical staffing is RN level. We plan to have a doctor present as well.
And so that people understand safe injection sites completely, it is a place where people can bring in heroin and inject it there, correct?
That's correct.
And that's,
Also, people are also entertaining the idea of safer consumption facilities so that other drugs could be used in these spaces as well.
what other drugs?
They're talking about across the board. They're talking about people being able to smoke, snort, all the ways that people ingest drugs.
And with respect to Ithaca, it's my understanding that the police department is not necessarily on board. And that would be a distinction between the Vancouver facility and Ithaca. And if that's the case, then how do you prevent the situation where people are arrested walking in or out of a safe injection site if you don't have the police department or the district attorney's office 100% on board? I mean, to my understanding, Vancouver, the police literally refer people to these safe injection sites.
They do. It's something that we are continuing to work on. I can tell you that the police chief in Ithaca went with us when he traveled to Vancouver and kind of absorbed some of the policing the way that they were doing it in Vancouver. He was not and is not yet on board with the idea of safer injection facilities, but his objection is that people are using illicit drugs and you're still, he feels, you're still kind of allowing that illegal trade to happen. The interesting part was we also visited the Crosstown Clinic in Vancouver, which is a different kind of program. Alan and I were talking about this prior to the debate. They have a pharmacy on site. They give people pharmaceutical grade heroin, and they come in 2 or 3 times a day and inject under medical supervision. Now, interestingly enough, the chief liked that program. And again, that probably fits in well with the law enforcement head because there's a lot more control over what goes on. But I see his point. You don't have legal drug trafficking going on, and you're actually pulling people out of the lifestyle portions of heroin use, which frankly is where most of the problems exist.
But is it feasible at this point in Ithaca, unless and until you have the police chief on board or the police department, to open a safe injection site?
We're working very closely with both the DA and the police chief, and I think that it probably was feasible in the short term prior to last night.
What happened last night?
We had a major election, and I think we have a federal government whose stance on how to deal with drug use will change substantially. And in my estimation, probably not for the better.
Alan, do you believe that successful treatment is possible for a person who is addicted to heroin but not ready to accept treatment?
Yes, I do. I think there are times when, and again, this comes back to my concern about how we view the illness of substance use disorders. We don't stop, for example, treating diabetes because someone has a problem with compulsive overeating. We continue to treat that chronic illness. We may treat it more aggressively. I think we have proven models in the country that we sometimes don't use as well as we could. Treatment courts are an example. We travel around the country, and I've had the privilege of doing that with the federal planning teams for Broome County. People who were involved in treatment courts around the United States with a mandated time of 2 years in treatment, many of whom were not ready to say they wanted recovery. They just wanted to avoid a consequence, and that's all that needed to happen for them to get into treatment court. 2 years later, you see them walk out the door with a job, having made some level of restitution for what their crime was, re-engaging with families, re-engaging with loved ones in their lives. So I do think that given a level of intervention when it's appropriate to get somebody, for lack of a better term, mandated to treatment, if the treatment is long enough in duration and continues to wrap support around the person, not just try to assign judgment and treat it as an illness, people absolutely do recover from this disease even when they came in to treatment reluctantly.
So would it be accurate to say that you believe that court-ordered treatment would be more likely to be effective if it were longer?
Oh, absolutely. I mean, we've seen cases, for example, where a judge will say, you need to go and get an evaluation and comply with treatment. They come and get an evaluation, it's clear we believe they need inpatient treatment. They're recommended inpatient treatment, and the managed care company says, well, it's court-ordered, but we don't think it's clinically indicated, and therefore, in the duration, they'll cut it off in 4 or 5 or 10 days. When we have judges that write an order for a specific number of days and force the Medicaid managed care company to pay for it, then people stay in treatment longer, and we have a much higher success rate at connecting them to the next level of care. We know that right now, people who complete inpatient treatment, who have an average length of stay of 14 days, connect to their outpatient level of care and are retained in that treatment for more than 30 days at a rate higher than 72%. That's very good performance compared to the state. We also know that people who are in treatment for less than 7 days show up at less than 30% to their outpatient provider. And so there's clearly a direct correlation between the length of time somebody has to stabilize in inpatient treatment and the likelihood that they'll be able to successfully engage and remain actively involved in outpatient follow-up.
Okay. This question came in from the audience, and John, this would be for you. What is the minimum age for a safe injection site?
The minimum age of someone who can use the facility?
Yes.
The minimum age for syringe exchange programs is 17, but I suspect for this intervention it might be 18. And the reason I say that is because it would probably be, when it was opened, it would probably happen under a research protocol, or some kind of special waiver from the Department of Health. So I would think 18 years old.
Okay. Alan, I have a question for you, and this is something that you and I had talked about previously. Do you believe in civil confinement in order to keep somebody in treatment long enough, or in a facility long enough where you believe that treatment will be successful?
I know that it's an unpopular position in many environments, but yes, I do. And I'll tell you why. We see people come through the emergency departments in both of our hospitals, time after time, who've been found overdosed in the community and have been administered Narcan. They're transported to the hospital. They're awake, they're alert. We have no ability to engage them in treatment or to hold them for a period of time, and they're allowed to leave the hospital. When I talk with some of our local police agency, they say, sometimes we have administered Narcan to the same individual 3 or 4 times in 1 week. Why can't you keep them in treatment? We have no ability to do so. The recent change in the law, it's called the 22.09 law, which allows a law enforcement person to bring someone to the hospital if they're incapacitated by a substance in the state of New York. We are obligated as a hospital to release that person as soon as they are no longer incapacitated. The law now states we can hold someone for up to 72 hours. The condition of that law is they still have to be incapacitated. And that's a stretch, because they're not incapacitated. They're well-oriented, they're alert, they're oriented, they can function. And so we have to let them go. My concern is that this serial overdose and administration of Narcan can lead to, if a person is overdosed too long, hypoxic brain injuries, permanent damage to the person's health. And if we have someone, and I'm not saying it should be everybody, but if we have a certain threshold that's established where someone is really demonstrating that they are so out of control with this illness and they are knocking at death's door every day, that the ability to hold them for a period of time and try to perform a more thorough assessment of a couple things. One is, can we help them get to treatment? Two is, do we have an individual who's actively trying to commit suicide without writing a suicide note? And most literature that you will review relative to the overdose rates on opioids state that most are listed as an accidental overdose. But we really don't know that. We don't know how many people are so burdened by this illness and so overwhelmed by the struggle they face every day to try to overcome it. Did they finally just say, you know what, this bag may be it, and it's okay with me if I die? And some may be intentionally using the substances to that level. My concern is that if we don't try somehow to create an intervention that helps that person at least have the opportunity to access treatment in a more thoughtful way, we may lose more people.
How long would you propose that people be, or that there be, what would the law say, I guess, is the best way for you to put it? How long could somebody be confined?
You know,
The outer.
Sure, it's an interesting question. If I look right now at the way the mental health law is, the mental hygiene law, if we think someone is a danger to themselves or others because of a psychiatric illness or because of suicidal ideation, we have two physicians examine them and say, I think this person poses a danger to themselves. They can be held for up to 60 days. They can be discharged anytime in the interim if they demonstrate that they're stable or healthy. I certainly wouldn't think it should be longer than that. I do think it's something that should be discussed. I think it should be discussed as a collaborative view between harm reduction, prevention, treatment, and law enforcement to say, and OMH and OASIS both, through their legal counsel, to say, is there a way to provide this intervention without violating civil rights, but trying to ensure the safety of the individual? And I don't know what the time should be. I do think, though, that just treating someone with Narcan and letting them walk back out the door day after day after day poses a greater risk to their life and safety. And I would like to see us have the ability to hold them for a period of time, clear them, and try to help them engage in services.
What do you think of that?
I'm not a fan. Treatment has its own set of problems. So even if you get somebody clear-headed enough to admit that they need that, 79% of the people that come into our syringe exchange programs have already been through treatment, sometimes multiple courses of treatment. And what kind of treatment are you talking about? Are you talking about medication-assisted treatment? Are we talking about white-knuckling it through abstinence-based treatment? Are we talking about 12-step treatment? Why are we even offering 12-step treatment? Here's another question for you. 77 years later, why are we even offering that to people? It's free of charge. Why are insurance companies and taxpayers paying for that? So, no, I'm not a fan of retaining people against their will. A lot of the people that...
Is that because you believe it wouldn't work, or is it because you believe there's a fundamental civil right at issue there?
Both.
And you do believe there's a civil rights issue there?
Yes, absolutely.
There's a clear distinction between the way both of you see that. When you say that people have already been through treatment, how long? I mean, do you track the length of treatment they've had?
We haven't gotten into that level of assessment with people, but our programs are anonymous, but we do a short intake with people, and we do ask them questions about if they've been through treatment. And again, right around 79 or 80% of folks have gone through at least one course, sometimes multiple. If you look at the literature, it's not unusual for anywhere from 3 to 7 courses of treatment for people before they're able to abstain from drug use. So we're fans of treatment. We send people to treatment all the time. I don't think it's the cure-all that it's purported to be.
And I know your thoughts on that in a minute, and I'll get to that in a minute, but I want to ask some specific questions about safe injection sites. I think when people hear it for the first time, they have questions, and I'm hoping that I can give voice to some of them. If somebody comes into a safe injection site, how do you validate or verify what they're on when they get there? Or if they're on something when they get there? How do you know?
Our staff are pretty adept, believe it or not, at doing an assessment of someone and seeing where they are. If they're actively nodding out, I mean, it's pretty easy to look at somebody and do a physical assessment. You look at their eyes and how they're carrying themselves. I'm sure Alan would tell you the same thing. That it's not difficult to tell if someone is very high when they're talking to you.
If someone is very high, do you let them shoot up anyway in a safe injection site?
We would probably advise against that.
Would you stop them?
Yes.
And
we would have the medical staff involved.
If people come in and they're obviously bringing their own drugs, do you test the drugs that they're taking to make sure that it's not carfentanil laced or fentanyl laced, that it's just heroin? But I mean, certainly in the era now of fentanyl and carfentanil, we're looking at an order of magnitude of up to 10,000 times the potency of morphine.
Yes.
And do you test, or do you envision testing the drugs before they take them?
I don't know if the technology is there yet to test for some of those agents. I think it will be in the near future. There's certainly people that are working on it. But will that be a component of the program if it was to open today? No, unfortunately, I don't think it would be.
The response would be essentially Narcan.
Or oxygen. A lot of people that overdose, we had a discussion with the Australian program, and the physician there said that they actually very rarely use Narcan, because usually oxygen and medical support usually gets most people through the other side of an overdose.
And ordinarily the overdose, it's a respiratory depression, correct?
Yes.
Okay. And this is another question that came in from the audience, and actually this would be for you, John. Would there be a mandatory limit of consumption at a safe injection site? I mean, is somebody, how much is somebody going to be permitted to inject in your presence?
Well, there's an intake process, and you would talk to the person about how much they customarily use. And again, when we were in Vancouver, the staff addressed that issue with us. They said, we keep track of people. There's 600 or 700 people through here injecting daily, but they get to know folks pretty well, and they keep an eye on that. But is there going to be a chart that says this person shoots 5 bags a day? No.
Well, in the context of heroin addiction, you define successful treatment as abstinence from all substances.
No. Hey, we have a lot of different levels of care that we provide here in Greene County. And we have an abstinence-based track for people. We also have medication-assisted treatment that we provide both through a methadone clinic, which is a sort of federally supervised treatment program, and we also offer buprenorphine through our standard outpatient clinic licensed by OASS. And we also have begun now to offer Vivitrol injections to inmates who are being released from jail, kind of trying to get at what John was just describing. that the counseling that's now being funded to be in the jail through OASAS, which is the Office of Alcohol and Substance Abuse Services, allows people now to elect to receive an injection of a drug called Vivitrol, which is long-acting naloxone, so that when they leave, if they do use an opioid, it will block the effect of that opioid in their body. And that lasts for about a month. And then one of our physicians sees them within a couple days of release from jail. We connect them to structured outpatient services and continue to administer that medication. So in our methadone program, we know that when people walk in the door, they used heroin the day before or some opioid, or they may have used it that day. We evaluate them. We expect that they're going to continue to relapse for a period of time as they stabilize, and we work with them. I met with a patient just this week who's been with us for several years, and every few months, you know, this person has a relapse, either on alcohol or marijuana or cocaine or some other substance. And we work with them to try to re-engage them in the treatment process and to try to restabilize them. But most of the people, not all, but most of the people that we have in methadone treatment will experience relapses throughout the course of the time that they're with us. So we don't see those as failures at all. We work to try to get those people re-engaged with treatment and re-engaged with services. We have similar structures, and we do work toward abstinence from all those other drugs, but it's not an expectation when they walk in the door. I think it's unrealistic to think that would happen. The same is true with buprenorphine. We work with people. There are some drugs that we're more concerned with than others. As an example, benzodiazepines. People who have a substance use disorder with opioids often have a benzodiazepine use disorder as well. And the combination of an opioid or an opioid agonist type of drug, methadone, heroin, any of those, and the benzodiazepine is particularly lethal. And so we are very, very cautious, and we talk with patients that we need releases to speak with physicians so that they don't get prescribed those classes of medications which can lead to very, very high risk overdose.
Let me ask about the follow-up on one thing you said about being given Vivitrol as you're leaving jail. From what I've been able to see in the research preparing for this debate, there seems to be a massive need, and correct me if I'm wrong about that, you certainly know more about this than I do, but for people who enter jail, they're in the midst of, well, in some cases it becomes an immediate forced detoxification, or people who are on Suboxone or on methadone. They no longer get it the moment they go in. Is there any effort being made to address that?
It's been an ongoing point of contention between, retention facilities or incarceration facilities and treatment facilities for decades. It's not a new situation here in Broome County or around New York State. There are some jails who provide medication for detox, but very few. Most don't. And again, I would go back to what I said in some of my opening remarks, which is we as a country do not view substance use disorders the way we do other disorders. If we arrest a diabetic and they go into jail, they're going to get their insulin tomorrow, and we're going to check their blood sugars. If a person comes into jail and is dependent on an opioid and starts to develop withdrawal, we should safely treat and manage that withdrawal as we would any other physiological illness, because at that point, that's what that is. And whether it's alcohol withdrawal or opioid withdrawal, any of the ones that are going to require medications, those should be thoughtfully and carefully administered, and we should treat it as we would any other illness of a person who's incarcerated.
What is the resistance under circumstances where you are in custody as more than one person? It's not to deprive somebody of their freedom. You are responsible for their well-being and the well-being of the other inmates and the staff. What is the objection to medicating somebody who is in the midst of withdrawal, considering the nature of the withdrawal and how it can represent such a threat to everybody around?
I really think it falls into multiple categories. I honestly do. I think in some settings, it's purely a punitive measure. You broke the law, you bought and sold drugs, you used drugs, you shoplifted, whatever you did, and now you're here. This is the consequence you're going to pay. You're going to go through withdrawal. That's part of the result of your decision. So in some cases, I think it's just a punitive mindset. In some situations, I think it's ignorance. I just think sometimes people don't understand the severity. Now, alcohol withdrawal is different. You can die from alcohol withdrawal. You can have grand mal seizures. You can have delirium tremens. You can physically die from it. And so you have a better chance with alcohol withdrawal of getting some treatment because it's potentially fatal. I think there's a widespread level of ignorance about the severity of symptomatology that is opioid withdrawal. I don't think people understand it. And I've had the privilege of talking to so many people who have gone through it. The pain, the intensity of it, the illness, the nausea, the vomiting, the restless legs, all of what is accompanied by that. I think there's an ignorance about it, and that is furthered by the fact that I'm sure there are people incarcerated who will act out in certain ways in order to try to avoid something. And I think people's mindset is this is a person who's acting out rather than this is a person in severe opioid withdrawal. So I think ignorance is the second factor. And then, and I don't know how much this one plays in, I do think that many of our jails, because they have a contracted medical service, that medical service is looking at cost, and they will do whatever they can to avoid spending money. And while generic buprenorphine is relatively inexpensive, it does have to be prescribed by a doctor who has to go through a course and get their special DEA number and has to be able to prescribe that medication. So there are costs associated for that contracted company. And how much that plays in, I don't know. I've not talked with the medical providers about it, but I do think that all three of those can play into it.
Question for John Barry. Are people who shoot up at a safe injection site, as you envision it, required to stay on site for a certain period of time after they inject?
There is a what's referred to as a chill-out room, or at least there was in Vancouver. And yeah, we certainly would have a facility for that. We have a wellness room. It's where the washer and dryer are. You know, there's games. We do some support groups there. People can use the shower facility if they want. There's snacks. There's coffee. So yeah, we would certainly encourage people to do that.
Would you require them?
No.
I mean, are they safe to cross the street?
The staff would assess that, just as they do at, again, all
And
the other facilities throughout the world.
If the staff
Where
decided...
where no one has ever overdosed.
Well, that is true. And in Vancouver, which opened in 2003,
Yes. 2 to
Is
3
that
million,
a single guy?
individual injections during that time period. Not one single person has overdosed. Neither has anyone ever overdosed in any of the other facilities throughout the world.
Rob, is it appropriate to have a clarification? I know we can't cross talk, but
well, overdosed or died?
right. I think that's
Died.
the distinction.
Yes.
I mean, there's certainly been a
Yeah,
fair amount of
certainly
Narcan
people
administered.
overdose and are either given support or Narcan.
Was that the clarification?
Yeah, I think in the Vancouver site, in the 4-year qualitative study at the withdrawal, there were 1,000 overdoses that were potentially fatal that
Yes.
were intervened upon. But no one died, but there were over 1,000 overdoses in the facility.
And let me ask you this, John. Is it accurate to say that you believe that complete abstinence is not necessary? There is not the standard by which you would gauge successful treatment?
That is accurate. We prefer to look at people's level of functioning. And again, I think Alan would back me up on this, that people who are using Suboxone or methadone, or for that matter, insulin or antidepressants, are on drugs. But many of those people are very, very functional. So that's where we prefer to set the bar as level of day-to-day functioning.
Is it your experience that people can use small amounts of heroin and function?
It is my experience that we've done some research actually in several rural counties, and some of the people that came in and surveyed with us, what they call a CHIP, which means just occasional use here and there. One lady in particular sticks in my mind. She talked about how she used a great deal when she was younger, but she sort of came out the other side of that, and I'll put that in quotes, recovered. And then her line to me was, I'm on a very limited income. I pay my bills when I get paid, and if I have anything left over, I use a little. So yes, I believe that's possible.
Okay. As far as the safe injection site funding, and this is a question from the audience, who would fund it?
In the other countries where they exist, they are government-funded entities. And I think that would probably be the scenario here as well. But again, I want to stress something. The state of New York put out a report last year in 2015 about the number of ER visits, hospitalizations, all these sorts of things. And statewide in New York, opioid-related ER visits, if you could eliminate all those, you could save $11 million. If you could keep people who are hospitalized for opioid or heroin-related reasons out of the hospital entirely, and you costed that out at one night of admission, that would be $33 million to save. So there's a lot of money to be recouped in taking care of these folks in the community.
Do you believe that somebody that there is such thing as a functioning heroin addict?
I really haven't seen one. I've only been in this field for 35 years. But I haven't seen somebody who's actively using and functioning well. I have seen lots of people who are on medication-assisted treatment and are functioning extremely well. We have a lot of folks on buprenorphine who are very gainfully employed, fully employed, and very functional. We have people on the methadone program the same way. So I do think with medication-assisted treatment it can be successful. But I have not met a person who's actively using heroin and is functioning in their life.
And I want to get back to on the safe injection site, as far as who assumes the risk of something going wrong there. I mean, if somebody leaves the site and is either, do you verify whether or not they've driven there or how they got there? I mean, if somebody leaves that site and is involved in something that creates liability, it's really not as if that person can sign a waiver. I mean, they lack capacity to sign a waiver when they're at the safe injection site. Certainly after they've used the heroin, most likely before. I mean, how is the public protected from the liability created by the nature of what occurs at a safe injection site?
Well, I can tell you one thing is that, looking at the people who use our syringe exchange program, frankly, the majority of them don't drive. Many of them are homeless, but those who are not in that situation usually don't have transportation. They'll live right in town, walk, and use buses and those sorts of things. Those are all issues I suppose to be hashed through with our insurer. They're already covering the syringe exchange program, and they don't feel squeamish about that. And they've trusted us so far, and there have been no lawsuits. And I can't believe, frankly, that this would be too much different, I have to tell you the truth.
And this is a question from the audience, and I'm obviously asking, sort of testing the way in which a safe injection site would work, but with respect to whether or not it works, and as far as reducing not just mortality or death by heroin overdose at the safe injection site that has not occurred. In Vancouver, there has been a drop within a 500-meter area. Is that correct?
Yeah, 35% reduction in overdose deaths.
And by your standard, that's a success. Is that accurate to say? I don't mean 35 as opposed to 45. I mean keeping 35% more people alive until they can get treatment.
Yes, I would call that a success.
Alan, are you aware of any evidence that safe injection sites have resulted in an increase in heroin use?
No, in fact, I think most studies that have been done in the safe injection sites across the world have not indicated that there's been any increase there were a lot of public opinion concerns before the opening of a number of safe injection sites that heroin use would increase. I haven't seen a single study where that was borne out to be true. I do think that while the studies show that there was no increase in heroin use and no increase in property crimes, they also don't show any decrease in heroin use or decrease in property crimes. Part of my belief about that has been that people are still required to bring in illicitly obtained drugs to use, and so they still have to procure them by some illicit means in most cases. So it hasn't really reduced the property crimes, it hasn't reduced the level of heroin use. I do think it has, in some cases, reduced the number of fatalities because people are using it in a safer setting. I think there are some studies, though, also that show that people who are given methadone in an observed setting as a harm reduction model and are not held to other treatment standards but have methadone different than we can do it in New York State have seen far less use of heroin and a reduction in property crimes associated with them. So I think that methadone, if you're going to have a safe site, if you have a site for methadone to be dispensed, that has been shown to reduce both the legal problems and the use of heroin, illicit heroin, and it has reduced the level of overdoses. Even the non-fatal ones are significantly reduced with methadone as compared to a safe injection site where they're using an illicit drug.
And let me ask you this, because this is something that came up when you and I spoke preparing for this. You made the comment to me that rehab is an artificial environment.
Mm-hmm.
What do you mean by that?
There's no way that you can create for a person in an inpatient rehabilitation setting the stressors, the incredible pressure that their life has around them when they leave. John mentioned that a lot of the folks that they see in their syringe exchange are homeless. A lot of the people we see come to treatment are in that same boat. And there's no way to rehab where you're getting fed 3 times a day, somebody wakes you up, somebody cares for you during the day. If you have a medical problem, a provider sees you, where you have access to those services. Once that person's done with that and we send them back out into the world, especially in short term, they have not developed a set of skills to live with that level of stress. And so I think it's an environment that is created to be therapeutic, to try to teach people new coping skills, but it's not the life, it doesn't replicate the life they came from, and it doesn't replicate the life they're going back to. And that's why I believe firmly in an acute inpatient followed by halfway house or long-term residential service that allows a person to transition back to the community. And long-term outpatient treatment for me, sometimes extending well in excess of a year, and if they're on medication treatment, maybe many years, affords a person the opportunity to develop the skills they need to live safely and healthy in the community, surrounded by the stressors that are, in fact, a part of their lives. I think one of the flaws in many of the approaches we've taken to this illness is that there is no medication in the world that will fix a person's life. There isn't. We do have some medications that will help alleviate the severity of some of the symptoms that people feel as a result of this illness, but it doesn't fix the illness and it doesn't fix their life. And that's where I think treatment coupled with medications can be so much more effective, and especially if we have the ability to provide it over longer periods of time to afford someone the opportunity to develop those skills and to practice them and to feel far more confident.
What type of area, though, should be, or what type of housing, when we talk about halfway house or something of that nature, the ones that I'm familiar with are some of the worst drug areas in the city of Maine that people are sent to after they've been taught about avoiding people, places, and things. They are sent directly to the area where the people and the places and the things that they are living within.
I don't disagree with that. I mean, we work closely with Fairview Recovery Services, which is up on the hill, and they're out of that area. But people have to walk through a part of that area to get into any services they're accessing. I do believe that, just like with many of our mental health group homes, they're in depressed areas because the funding to provide them is very limited, and the reimbursement the providers get is very low, and they get facilities where they can. We also work, If you look at the Volunteers of America, any of those shelters that we have in our community, people work very, very hard to provide the very best service they can within the limited resource structure that they are offered to operate. And that's an unfortunate reality for both mental health and substance use disorder patients.
John Berry, have you approached Broome County to seek a permit for a safe injection site?
Have I approached Broome County?
Yes.
No, I have not.
Well, we had an election yesterday,
We had several.
but locally, the county level, is that something you will now be looking to do?
Not imminently. We're putting most of our resources and our efforts at this point into the community. Again, because we already have, we have a syringe exchange program here too. But the one in Ithaca has a lot more additional resources in terms of, we've already got medical people on staff there. We've got additional space with shower and laundry facilities, as I said. So that's probably, when we choose to pursue it, that's where it'll be happening.
And with respect to the Ithaca site, where would that be in Ithaca specifically? You had sent me an article and I read it, and it seemed to indicate that in order for a safe injection site to be truly effective, it needs to be where people are using heroin. And that's, where there's the largest concentration of people using heroin.
Sure.
Where is that?
And our office, where we have the syringe exchange, is on 314 West State Street. It's right downtown, right off the end, one of the ends of the Commons.
Do local businesses, are they fighting this?
Actually, the feedback that we've gotten from local businesses, I'm glad you asked that question, has been mostly positive, and that's because they keep finding people in their bathrooms injecting. And they keep finding used injection equipment in their bathrooms.
Okay.
So, and they see how we could help with that.
Would there be a limit on how many times per day somebody could visit a safe injection site?
I do not believe there would be a limit, but and we know from Vancouver that they generally don't see people any more than 3 to 4 times per day.
And what is the mental health treatment that's available or offered at a safe injection site as you envision?
Well, in Vancouver, they have detox right on site, and they have mental health services, but I'm sure you can appreciate that a socialized healthcare system is a little bit easier to navigate when it comes to things like reimbursement and the programs and that sort of business. We were just having a discussion about this recently, about how we would probably need to have a psychiatric nurse practitioner come in to backstop some therapists who would probably be MSW level people. That was certainly going to be a necessary service there. We know that a lot of the folks that we see have had histories of trauma. That's not a surprise to anybody in substance use treatment. So mental health is in the equation. So yeah, that would be a piece of the program that would have to be developed, no doubt about it.
This will be my last question for you. Has the Vancouver facility achieved a higher level of treatment, moving people to abstinence than something other than a safe injection site?
The research that I have read only talks about people with uptake of treatment and completion of treatment. And what they found was that there was a higher rate of people completing treatment than people who had not come to insight. And that's why one of the reasons that I'm not a fan of compulsory treatment. I think it's much more successful when people come to it in their own time and for their own reasons.
And are they moved along that process? I mean, is it purely up to them, or is there nothing paid in Vancouver to educate people to get away from that?
Just like
Help them through that addiction, I guess.
Just like in our syringe exchange programs, the question is always asked to people, is there anything else that you need? And that could be housing, it could be treatment, it could be, a bottle of water, it could be a shower, it could be doing your laundry. Is there anything else you need? Is today the day that I can refer you to treatment? And we have dedicated staff, again, who will get on the phone and get somebody into treatment. So, yeah, and I think I know they do the same thing there. Again, they have detox right upstairs in their facility. So it's as simple as walking up the stairs. The other thing the Canadian system and also the German system does a lot better than we do here is they incorporate housing into all these programs. So again, if somebody is homeless and they come in to access the service, it's very easy to plug them right into housing. That's critical to somebody staying well, reducing or stopping drug use, attending to their mental health.
And my last question for Alan, what role does fear of withdrawal play unique to opioid users as far as seeking treatment?
Again, as I mentioned about when I was talking about what I perceive to be a level of ignorance that people may have in the criminal justice system about how severe that it really is. Most people who suffer from an opioid use disorder have such a profound fear of what withdrawal is going to be that they will do anything they can in their power to avoid it. Most people who we see in medication-assisted treatment, as an example, are very clear about the fact that, you know, if their supply is threatened, if there's no ability for them to find a way to avoid withdrawal, they will do anything within their power. I think fear is something that is, you talk about fear being a great motivator. People are terrified of what that withdrawal is going to be because of the experiences they've had with it. And the reality that the level of sickness that comes from that withdrawal is overwhelming. And it overtakes a person, and it's not something that lasts for a day. Opioid withdrawal is going to last 7 to 10 days in its acute state if it's left untreated. And if any of us is going to suffer incredibly beyond anything we've ever experienced with a common flu, I mean, most folks will tell you take the flu and multiply it by 100, the worst flu you've ever had. If you knew you had to go through that for 10 days, or you had the opportunity to stop it now, you probably want to stop it now. And that fear is overwhelming. It's paralyzing for people, and I think it's poorly understood.
That is going to conclude this You Defended debate on opposing treatment strategies for heroin addiction. Thank you.